The next speaker is Dr. Bhoj Luitel from Nepal. He's going to talk us on open IVC thrombectomy, how we do it. Over to you, sir.
Respected chairpersons, seniors, and my friends, a very good afternoon to you all. I bring all the greetings from Kathmandu, Nepal, from Tribhuvan University Teaching Hospital and Nepal Association of Urological Surgeons both. For coming couple of minutes, I'll be talking on open IVC thrombectomy, how we do it. I don't have any conflict of interest to disclose. This is outline of my presentation. As all of us know that RCC and IVC thrombus is in the category of the locally advanced disease, occurs in the range of around 10%. In metastasis, it multiplied by 3 times. And natural history, if you leave untreated, then most of them succumb to death. For durable treatment response, you need to opt for operation. There is no other option for this at the moment. Keep in mind that not only RCC, other retroperitoneal tumors also lead to IVC thrombus formation, tumor thrombus formation. It's a challenging one because already I have highlighted the prognosis is dismal, and there is risk of embolization, high perioperative morbidity and mortality, and needs appropriate preoperative preparation, intraoperative care, and postoperative rehabilitation. In our hospital, Tribhuvan University Teaching Hospital, over the past 10 years, we have done around 38 cases. Most of them were level 1, but level 2 and level 3 for all category, and in few, and then osteosarcoma cases, and then Wills tumor, all category in tertiary level hospital, we do operate this, and gradually we are gaining the momentum of treatment for this. We start with clinical evaluation with history and physical examination, and we send for hematological and biochemical investigations. Imaging is the roadmap for treating this disease. CCT chest and abdomen, if you can see there, how the IVC thrombus is extending upwards towards the heart. You can have a look there. Ultrasound Doppler of the lower limb to see any DVT or not, and then MRI in selected cases we do whether there is IVC wall invasion or not to identify preoperatively, bone scan and MRI brain if symptomatic, otherwise we don't do routinely. You see this MR with coronal image with IVC thrombus, it has reached especially up to the hepatic vein confluence. This is one patient with level 4 IVC thrombus in right atrial thrombus. This was transesophageal. This is transesophageal echocardiography report, and we do transthoracic as well. It has 2 roles. One is to identify whether it has extended to right atrium or not, and other one is intraoperative real-time monitoring helps us to monitor whether tumor has shrinked or not, is there any shrinkage or not after renal artery ligation. All of us know that we follow the Bluet's criteria for Mayo's Clinic, level 0 to level 4. I don't want to go detail, but blunt tumor thrombus is other entity that can come. How to differentiate between these two: pattern of enhancement, contiguity with the mass, vessel size. Usually in tumor thrombus cases, the IVC diameter expands so much that it crosses more than 2.5 centimeter, even 4 centimeter also. Management of this patient, we should go in individualized approach. It has patient factors, tumor factors, and expertise and logistics availability. Perioperatively, we should take care of the risk of the pulmonary embolism. We need to start anticoagulation, warfarin or heparin bridging therapy. Routinely, we do not go for angioembolization. In selected cases, we go in those patients because there is risk of post-angio infarction fever and embolization risk also. We take the patient for the multidisciplinary team meeting, especially involving anesthesia, cardiovascular surgeon, and liver transplant surgeon or general GI surgeons. Incision and approach for infradiaphragmatic, we go in different way. For supradiaphragmatic, we go different way. But in our center, recently we have introduced modified Makuji operation. That is nothing but this L-shaped incision, reverse L or L-shaped incision. By that, there is good exposure, especially for IVC and caudal IVC. We know that for level 1 and 2, we need to mobilize both contralateral renal vein and IVC all, and renal artery to be ligated first, and taking care of the vascular thing. And for level 1, most of the times it shrinks, and you can apply the Satsky, and we can take it out. For level 2, of course, you need to do sequential clamping and declamping, caudal IVC, contralateral renal vein, and then cranial IVC. We clamp that and take out the tumor. For left-sided tumors with IVC thrombus, keep in mind that we have to clamp the right renal artery, not to let the congestion of the venous congestion in the kidney. You should cool down. You should have the facility of cooling down also if you are going to cross 25-30 minutes of warm ischemia time there. We should prepare for all. So after thrombectomy, do you need to repair beyond augmenting the IVC? If you can leave the more than 50% of the wall of the IVC, there is no need of augmentation. For level 2, many of the times you might need Langenbeck maneuver. Be prepared for that. We go for that. This is one interesting case with osteoblastoma with metastasis to kidney, right kidney, with going to renal vein, then IVC. So this young girl, we have done right-sided radical nephrectomy. If you see the bone pieces coming out, it's so hard one, and luckily we could take it out all. For level 3 and 4, the question it's more complex one because it's above the IVC hepatic confluence going to the subdiaphragmatic area or supradiaphragmatic area. For them, really, we need a facility of bypass and everything, and cardiopulmonary bypass, veno-venous bypass. We prefer in the cardiac surgery OT for these patients. Vascular control for level 3, of course, for level 3, most of the times, for Pringle maneuver, we prepare for that, along with complete liver mobilization by this Langenbeck maneuver, and then go suprahepatic, subdiaphragmatic access. We control there, and then after ligation of the renal artery, once the congestion comes out, the tumor thrombus shrinks, and then you can remove those tumors also by this subhepatic cavatomy itself also. You need generous lateral cavatomy along with ostium of the renal vein, and then you can do these things, and then heparinize and heparin flushing, all the things we do. Sequence of release is again same, caudal IVC, contralateral renal vein, Pringle you release, and at last you release suprahepatic IVC. Sometimes once the tumor comes down, you can release this Pringle and other one, and you can apply the Satinsky or clutch clamp just in the subhepatic space as well. So the question of veno-venous bypass, when to prepare the patients for bypass for level 3, because suprahepatic IVC clamp, all the patients may not tolerate. You clamp that and have a look for 2 to 5 minutes. If there is reduction in the cardiac output,
summarize?
In echo, then we bring, if there is 50% reduction in the output or mean arterial pressure decreases by 30%, then we need to go for veno-venous bypass. So cardiopulmonary bypass, of course, you should prepare for all. I do not want to go in detail about this. Patch capoplasty, if needed, we go with PTFE grafts or Dacron grafts. Replacement, very few cases. So postoperative management, it goes to cardiac ICU, and then we manage subsequently. So with this, I come to conclusion. Here is a small message from Nepal that 1st and 2nd March 2024, our 9th Eurocon will be held at Hotel Mechi Crown, Dhulabari, Japa. It's very near from India and Bangladesh, and we love to invite and welcome you all of you there. Thank you very much.
Thank you so much, sir.